Good evening, everyone. It's my pleasure to welcome you all for this wonderful Bodhana series, 15th series of Bodhana, which was initiated last year by TNFOG with a great initiative by TNFOG Secretary, Vice President Sampath Kumari ma'am, and also President at that time, Anjalakshi ma'am. And this has been successful over the past few years. Every month we have one PG case discussion from different medical colleges, and we have experienced teachers who will be sharing their knowledge and experience. It's my pleasure to welcome you all for this program. It's my privilege to welcome our TNFOG President Revati Janakiram ma'am, who doesn't need any introduction, but formally, it's my pleasure to invite ma'am, past Vice President FOG and also former Director of IOG Chennai, Founder Secretary and past President of Madurai OG Society, Founder President of IMS Madurai Chapter, President Madurai Chapter of TAPISAR, recipient of various awards, Durusha Community Award, Lifetime Achievement Award, and she has written various chapters and authored various books. Welcome you, ma'am, for your welcome address.
Good evening, dear friends. It's indeed my great pleasure to welcome you all, dear students and teachers, Dr. Kalyani, Dr. Rajarajeshwari, and Dr. Padmavati, to this wonderful program of Bodhana by TNFOG. I have to really appreciate Dr. Sampath Kumari for initiating this Bodhana, which is really a boon to every postgraduate. And not only PGs, even practitioners are eager to attend this because they would like to update their knowledge. So in that way, it is really very, very useful. And I wish you all the best, and we can move on to the classes.
Yes, ma'am. Thank you, Revati ma'am, for your welcome address and blessings for this program. Now we have senior teachers and experienced consultants. It's my pleasure to invite our examiners, Rajarajeshwari ma'am, who is a professor HOD, Department of Obs Gyn, Thanjavur Medical College. Madam has received Vadamalayan Award and Annamalayan Award, University first when she was doing MBBS, and now she is the present treasurer of Thanjavur OG Society. And she has got an experience of almost 30 years, and she has received various awards, including Best Doctor Award. Welcome, ma'am.
Thank you, ma'am. Thank you very much for your kind words. Thank you very much, ma'am.
It's my pleasure to welcome our next examiner, Kalyani ma'am, who is a HOD and Chief Gynecologist in Railway Headquarters Hospital, Perambur. Madam has cleared UPSC and joined in Railways in 1990, and she is a member of various prestigious organizations, and Madam has been a faculty in various national and international journals and published various papers. Welcome you, ma'am.
Thank you.
Our next examiner is Padmavati ma'am, who is a professor in Institute, and Madam has got an experience of almost 30 years, retired as Deputy Director of IOG, published various papers in national and international journals, and she has been guiding various postgraduates, and Madam is again a member of various prestigious organizations. Welcome, ma'am. Our next presenter here is Dr. Tamil Ilakia, who is a third-year postgraduate from Thanjavur Medical College. The co-presenter today is Dr. Gomat from Thanjavur Medical College.
All the best, dear students. We can start.
Thank you.
I need you like that. Yeah, over to you, presenters.
Okay. A 29-year-old Mrs. X residing in
Sorry,
Mumbai.
ma'am. Slides are not visible, ma'am.
Share your slides.
Okay, ma'am.
Yes, it is seen.
Okay.
Yes, ma'am.
A 29-year-old Mrs. X residing in Karandai studied up to 8th standard. Her husband is a farmer by occupation, belongs to socioeconomic class and who is a second gravida, para 1 days of gestational age, and referred from Karandai PHC as hemoglobin 8.5 grams per deciliter with complaints of EC fatigability for past 2 weeks. History of presenting illness. History of EC fatigability for past 2 weeks. Able to perceive fetal movements well. No complaints of lower abdominal pain. No complaints of bleeding PV. No complaints of draining per vaginum. No complaints of swelling of both legs. No complaints of difficulty in breathing. No complaints of chest pain, palpitation. No complaints of orthopnea, paroxysmal nocturnal dystonia. No history of decreased urine output. No history of headache, blurring of vision, epigastric pain, vomiting. No history of chronic cough. No history of difficulty in maturation, burning maturation. No history of chronic fever. No history of loss of sensation or ulcers over mouth. No history of leg ulcers. No history of hematemesis, bleeding per rectum. No history of yellowish discoloration of urine. No history of EC bruising or prolonged bleeding after injuries. No history of barefoot walking. No history of passage of worms and stools. No history of chronic renal disease. No history of blood transfusions. Her menstrual history. She attained menarche at 14 years of age and regular cycles over 30 days per cycle. Normal flow and she changes 3 to 4 pads per day, not associated with the pain and passage of clots. Her LMP was 17/4/2022 and EDD 24/1/2023. Marital history, marriage since 3 years, non-consanguineous marriage, living with husband. Post-obstetric history, gravida 1, she delivered full-term normal vaginal delivery, an alive boy baby of birth weight 2.5 kg at Karandai PHC, spontaneous conception, booked and immunized at Karandai PHC. All 3 trimesters were uneventful. No history of pregnancy-induced hypertension, antepartum hemorrhage, no history of iron sucrose infusion, blood transfusion in antenatal period. She went into spontaneous labor. There is no history of premature rupture of membrane. No history of postpartum hemorrhage, discharge on postnatal day 3. No history of iron sucrose infusion, blood transfusion in postnatal period. Patient took iron and calcium supplements postnatally for 1 month. Exclusive breastfeeding given up to 6 months of age. Complementary feeding starts from 6th month. Breastfeed till 1 year of age. Currently 2 years of age. Immunized till date. No contraceptive used in the interpregnancy period. She resumed her menstrual cycle after 6 months of lactational amenorrhea. History of present pregnancy. In first trimester, spontaneous conception, pregnancy confirmed by urine pregnancy test at PHC after 2 months of amenorrhea. Dating scan done and said to be correlating with their last menstrual period. Booking investigations done and all are normal. No history of fever with rashes. No history of radiation exposure. No history of teratogenic drug intake. No history of bleeding, spotting per vaginum. Immunized with the TB. History of folic acid tablet taken. In second trimester, quickening pursued at 5 months of amenorrhea. The targeted imaging for fetal anomalies scan done. No cross fetal anomalies detected. No history suggestive of gestational hypertension and gestational diabetes mellitus. GCT within normal limits. History of tablet albendazole taken. History of irregular intake of iron and folic acid tablets. Patient gives history of constipation and epigastric discomfort after taking iron and folic acid tablet. So she took iron and folic acid tablet for once in 2 or 3 days. No history suggestive of urinary tract infection. In third trimester, able to persist fetal movements well, no complaints of lower abdominal pain, no complaints of bleeding per vaginum, no history suggestive of gestational hypertension, gestational diabetes mellitus, growth scan done at 32 weeks, so fetal growth restriction, GCT repeated found to be normal. Patient gives history of EC fatigability for past 2 weeks, for which he went into coronary PHC, found to have hemoglobin 8.5 grams per deciliter, for which patient was referred to RMH for further management. Past history, not a known case of hypertension, diabetes, tuberculosis, heart disease, seizure disorder, and thyroid disorder. No history of major abdominal surgeries. Personal history, she consuming mixed diet, normal bowel and bladder habits, no history of substance abuse. Family history, no history of bleeding, coagulation disorders in their family members. General examination, she is moderately built and nourished, moderate pallor plus, no pedal edema, not dyspneic, not tachypneic, not icteric, no cyanosis, no clubbing, no generalized lymphadenopathy, nails normal, JVP not elevated. Her height was 149 centimeters. Pre-pregnancy weight was 48 kg. Present weight 54 kg. Pre-pregnancy BMI 21.6 kg per meter square. The thyroid, breast, spine all are normal. Vitals. Blood pressure measured in sitting position in right arm is 110/70 millimeter mercury. Pulse rate 86 beats per minute. It's regular in rhythm. Good volume. No radio-radial or radio-femoral delay. SpO2 99% at room air. Systemic examination. Cardiovascular system S1 S2 here. No murmur. Respiratory system normal. Vesicular blood cells present. No added zone. CNS no focal neurological deficit. Diet history. She took total calorie 1645 kilocalorie. Total calorie required for this patient 2100 kilocalorie and calorie deficit was 455 kilocalories. Total protein required for this patient 60 grams per day, but she took total protein 48 grams per day, deficit 12 grams per day. Abdominal examination. For inspection, abdomen longitudinally distended, umbilicus in midline, flush with the surface, linea nigra present, stria gravidarum seen, no visible scars, sinuses, and dilated veins, hernial orifices free. Palpation, uterus relaxed, not tense, not tender, uterus enlarged to 32 week size with flanks free, clinically adequate liquor. Symphysis fundal height was 32 cm, abdominal grip 92 cm, obstetric grip. Infantile grip, sharp, broad, non-palatable, breech felt in upper fold. In umbilical grip, continuous curvilinear resistance. Back of fetus was palpated on left side. Irregular multiple knob-like structures suggestive of limbus on right side. In first pelvic grip, hard, round, independently palatable, mobile head felt in lower fold. In auscultation, fetal heart sound heard around left side of spino-umbilical line, which is 150 per minute. Local examination, external genitalia normal, no show but draining per vagina. Summary, a 29-year-old SSX, second gravida, para 1, living on previous normal vaginal delivery and who was booked and immunized at Karande PHC, belonging to socioeconomic status 4 at 35 weeks plus 5 days of gestation, referred from Karande PHC as hemoglobin 8.5 grams per deciliter with complaints of EC fatigability for past 2 weeks. On examination, she was found to be moderately anemic with a single live fetus in longitudinal lie in cephalic presentation with a good fetal heart rate and adequate liquor with intrauterine fetal growth restriction, admitted for anemia correction and further management. Provisional diagnosis, a 29-year-old Mrs. X, second gravida, para 1, living 1, previous normal vaginal delivery with a 35 weeks and 5 days of gestation, with a single live fetus with a cephalic presentation, with a moderate anemia, with a fetal growth restriction, without signs of cardiac failure.
What are the causes for anemia in this patient?
In this patient, there is a short interpregnancy interval. When previous child was only 2 years old, there is no adequate time for replenishment of the previous iron loss. And one is a short interpregnancy interval, and the other one was she is not taking a prophylactic iron supplementation due to the discomfort or epigastric pain and constipation. And their dietary requirement is also not good. Inadequate dietary intake also leads to anemia in this patient.
And she also iron folic acid also not properly taken, ma'am.
Okay. How does socio-economic status attribute as a factor of anemia?
Hello, can you able to hear me?
Madam?
Hello? Can you able to hear me?
Yeah, yes, madam. Yes, madam.
madam.
Yeah,
morning,
history taking, no?
Yes, ma'am.
So
Good
there's
evening.
no need to write all this negative history.
Yeah.
Yeah,
First of all, no. Nearly over 15 to 20
Yeah,
history was
uh,
there. What was the positive salient features for this patient? I was finding out, but nothing was there.
nothing
But
was
endo
there,
history
yeah.
was there. Yeah.
Okay, ma'am.
So you have to find out.
Madam,
Padmavati
couldn't
ma'am,
hear you.
you are muted. Please unmute
Hello?
yourself and then.
Yes, ma'am.
Yes, ma'am.
Yeah, you can ask multi number of cases, history, but you have to write only positive. So
Okay,
here is obviously he is not taking iron tablet regularly.
yes,
So
ma'am.
that is a PhD when doctor mistake. So you are elicited this history, but that mistake is only by PhD side. Okay, and then whether you didn't ask for whether they are doing hemoglobin every visit. If you have done this 8.5 from 10 hemoglobin itself, you have picked up the case and rectified the defect. Okay, so only history taking drug. This history obviously is a nutritional, iron deficiency and nutritional. So no need to write all these negative points. Okay.
And moreover, she didn't take iron for 6 months at least to replenish the stores. She has taken post partum only for a month.
Like
Correct, no?
theory part, you have written everything. On examination, that is the question of JVP in 8.5 gram hemoglobin. Tell me, when the JVP will rise? Hello? So, if you know all the subject, no need to write or tell in a single case. Salient to that particular patient, the relevant features only you have to write and tell. Even though you know 110 subjects about anemia, okay? As though you are testing us, that whether we know it or not. That is not your attitude, okay? You have to tell pertaining to that patient only. You need to tell all the subject what you know in the exam, okay? So no need to write JVP here. Being 8.5 gram hemoglobin. And then you have diagnosed that it is due to anemia. Where is the question of this preeclampsia, imminent eclampsia, cysty and all? This is too nonsense, no? I mean, BP is 110/70. Why the hell you are writing this? This no imminent symptom. This is all negative marker. As a PG student, the UG they can write anything. But PG as a consultant, after history taking, you have arrived some diagnosis. Pertaining to diagnosis, you can write it. If the examiner asks only, you can, what are the DD for epidel edema, what is the DD for something, you can tell. Okay? So elaborate, not you are not confined to your diagnosis. Okay? Thank you. And then examination also. Where is the question of tenderness? Not tender, not tense. You tell me. In this case, where is the question of not tense, not tender? If it is a tender and tense, the patient itself has complained of pain. You are thinking of abruption in anemia. But in this case, it is not there, no? Why are you writing not tense, not tender? This is also wrong in the examination. Okay? Madam, others, Kalyani Madam, Rajesh
Yes,
Madam.
ma'am. Yes, ma'am. I'll ask. How does socioeconomic status attribute as a cause of anemia? You told it is she is stage 4, no?
Yes, ma'am.
Class 4 socioeconomic status. Unmute yourself. I couldn't hear you.
Yes, ma'am. Most of the iron-rich ingredients, meat and meat products are usually bit costly, ma'am. When the patient belongs to low socioeconomic status, it's not possible for her to buy every day to overcome her iron deficiency, ma'am. So in this way, the cost of that iron-rich food items to buy makes the socioeconomic status important for this for us to know about the status of the patient.
Not only that, in low socioeconomic status, the gender discrimination is also very high. Females feed the family first and then they will take at the last, the remnants. So that also plays a role, which it is left out what they are eating is not contributing to the amount of iron which is needed or calorie which is needed. Okay, and then you have told in diet history also, instead of 2200, she is taking 1650 kilocalories. So there is a deficiency of calories also. So which is going to attribute as a cause. So per se, she is taking a low calorie as well as she may not be able to get a high rich protein or a iron diet. But she is a booked and immunized patient. If a patient is booked and immunized, how can she be a anemic patient? In what way she has become anemic? In what way we have failed? That plays a more important role. One thing is they didn't do the hemoglobin every visit. First thing, if they have picked up in the thing, otherwise also so many patients booked and immunized will come with anemia. What must be the reason?
Dr. Kalyani, sorry to interrupt. See, some students are replying in the chat box also. You please, some of them.
I'll see.
Somebody has written that worm infestation in low socioeconomic group. So please note that also and discuss. Thank
yes,
you.
ma'am. Yes.
Okay.
Tell ma, if they are already booked and immunized, they will be having some amount of anemia. What must be the reason? In what way we have failed?
Yearly trimester also from PHC level.
That is because of vomiting. And early trimester we are not giving. After 14 weeks only we are giving. Till 14 weeks we are giving only iron-rich diet and folate. Because the thing is, we are not explaining the patient how to take iron and calcium. Together, if you ask the patients, after meals, together they are taking. So calcium is the chelating agent which is going to chelate iron and it is not going to get absorbed. So even if they take also, it is going to be excreted in the feces. So it's not going to help the patient. So we have to counsel the patient, either she has to take iron tablet before meals. If she can't tolerate, take it in between the meals after at least after that, then she can take iron tablet with the vitamin C or any fruit juice. After that, 1 hour after meals, she has to take calcium. If you just give iron and calcium 60, go and take morning one, morning and night. If you explain in that way, they will definitely take correctly, but not in a correct way. They will land up in anemia only. Okay. What is the percentage of absorption of iron from the gut?
Only 10%.
Yeah.
So 10 to 20%.
10 to 20%.
Okay. Can you hear me? Daily requirement of iron?
In pregnancy, first trimester 1 milligram per day, ma'am. In second trimester, it will be increased to 4 to 6 milligram per day, ma'am. In third trimester, 6 to 8 milligram per day.
How much absorption is it?
Only 10% will be absorbed, ma'am.
If you are giving 60 milligram, only 6 milligram, 10%.
Accordingly, you have to give.
Yes, ma'am.
Excuse me, madam. Madam, excuse me. In National Anemia Prophylaxis Program, only to avoid the this incompatibility between iron and calcium, the pregnant woman is advised to take iron in the morning and night, whatever it may be. If it is prophylactic at night, or if it is therapeutic both morning and night, and calcium should be taken in the afternoon, so that the absorption of iron is not interfered by calcium, which is a chelating agent. That is the instructions given in National Anemia Prophylaxis Program, and we are also following our statal society.
Everybody is following that only.
Yes, ma'am. Yes, ma'am. Just as an afterthought, I added.
Okay. Classification of anemia.
In ICMR class.
Classification.
One classification you tell. Calmness we are using.
According to ICMR classification, mild, moderate, severe, and very severe. In mild degree, hemoglobin would be 10 to 10.9 grams per deciliter.
Yes.
In moderate degree of anemia, 7 to 9.9 grams per deciliter. In severe anemia, 4 to 7 grams per deciliter. In very severe, less than 4 grams per deciliter.
Okay, you know that anemia is not even the, this is, you have to identify the etiology cause. What are the commonest cause for anemia in pregnancy?
Nutritional anemia, ma'am. It may be either due to iron deficiency anemia, or vitamin B12 deficiency, or folic acid deficiency, or increase.
Other causes?
Acute blood loss due to
Acute
chronic
blood loss. Acute blood loss.
Acute
chronic
very
blood
rare.
Chronic blood loss maybe any hookworm infestations, hematemesis, hemorrhoids,
Or a malarial parasite infection, ma'am, there will be chronic blood loss. Or due to hemoglobinopathies, if the patient is having any
What the commonest hemoglobinopathies you know?
sickle cell anemia,
Thalassemia.
Thalassemia.
Diagnose thalassemia.
In thalassemia, we will be getting a peripheral smear picture of microcytic hypochromic anemia. Usually, we will be treating the microcytic hypochromic anemia with iron supplements and the blood transfusion. Iron supplements.
Yeah, I'm asking diagnose. How will
How
you
will
diagnose?
you diagnose thalassemia?
hemoglobin
Electrophoresis, ma'am.
Before that, any clinic, any test?
Nestrov test.
What is fragility test? Osmotic fragility test.
Nestrov test. Naked eye
What
single
about the-
tube.
What about blood indices? Is there any difference in blood indices of iron deficiency and thalassemia?
What is the
Yes,
peripheral
ma'am.
smear? What is the LCH, NCHC?
in
NCHC NCH will be
also decreased, ma'am. In red cell distribution with also decreased, ma'am.
what about NCHC? NCHC. It is increased or normal or
It will be
decreased?
normal or increased. It's a normal, ma'am. Total iron binding capacity and the serum ferritin will be in a normal value, whereas in iron deficiency anemia will be decreased and total iron binding capacity will be increased.
Okay, what is the how will
So
you
it is a
diagnose?
normocytic normochromic anemia. In thalassemia, it will be a normocytic.
Microcytic microchromic only.
Microcytic microchromic will be in
Microchromic
iron
only.
deficiency.
Yes, ma'am.
Okay.
Yes, ma'am.
Will you give iron in thalassemia?
No,
No,
ma'am.
ma'am.
It will lead to
Why?
iron toxicity because the patient will be already undergoing repeated blood transfusion as a treatment for thalassemia. If we supplement with the iron, it will
No,
lead
no,
to
no, no. Repeated blood transfusion is not the reason. Here,
ma'am.
the thing is, it is not the deficiency of the iron. It is the what is the defect in
Hemoglobin.
thalassemia?
It's a defective
Synthesis, structural globin.
defect in the globin.
It's structural globulin itself,
Structural
alpha chain,
globin
beta chain. So alpha
Yes, ma'am.
thalassemia or beta thalassemia.
Beta
If you are
thalassemia,
going to give iron, it's not going to help. It will cause iron toxicity
Iron
and patient may.
toxicity.
So the corrective, this thing for thalassemia is only blood transfusion.
Blood transfusion.
Okay.
Okay, ma'am.
Okay, in this patient, why menstrual history is very important. We'll come from the history. Socioeconomic status from the history. Now, why menstrual history is important in anemic patients?
Previous history of menorrhagia will cause anemia.
Correct. Tell. So, preconceptional status of anemia may also contribute as a factor for this patient if she is having a menorrhagia history. Okay. And interpregnancy interval also matters. It is only 1 year and now the child is 2 years, you told. So in between she conceived. After 6 months of the lactational amenorrhea, she started bleeding and then conceived. So it is very less interpregnancy interval. And third factor is she never took iron for storage replenishing. It was not taken. We are advising 6 months iron, but she has taken for only 1 month. Yeah. So all these things, factors plays a very important role. So preconceptional iron status also very important. When the patient comes to you for a booking itself, you should do everything, CBC as well as fasting blood sugar, and it is a screening. If you pick up anemia in the first visit itself, you can advise the patient what is the nutritious diet, how it can be taken, and you can tell her how to, even if she doesn't tolerate iron in the first trimester, you can give her iron rich diet. What do you mean by iron rich diet?
The substance, meat, liver, and moringa leaves, jaggery. These are all items which is having very high iron content. We can advise the patient to take frequency
which type of meat? Since you told it is a meat is important, which type of meat is important to increase your this thing iron content?
Liver.
No, which type of meat?
Red meat.
Red meat, ma'am.
Yeah, why red meat? What do you mean by white meat? What do you mean by white meat? If you tell red meat, there should be some reason for other this thing, no, opposite. So white meat is also there. What do you mean by white meat? It is a halal meat. When they do a kurbani, they cut the carotid of this thing and then they will bleed. That is only called kurbani. So only Muslims will take only the kurbani, that halal meat. That type of meat is not going to increase your iron. So iron only increases the iron content of your this thing and decreases the anemia. When you take a halal meat, it's not going to help you in any way. So we'll ask the patient to take baai kada mutton vaangadinga sollanum. Okay. So they will do that carotid. They usually cut the carotid, bleed the goat, and then only cut it. Okay. Good one. And then, so history-wise we have come, and menstrual history we have come. Obstetrics history, which is the significant point here. Interpregnancy interval, you already told. Anything else?
Postpartum
iron took only iron.
Anything else? Did you ask about any contraception?
Yes, ma'am. She didn't use any contraception.
They have written no contraception.
Any history of abortions in between? No.
No, ma'am.
So in between, when she bled after lactational anemia, any AUB she was having, menorrhagia?
No, ma'am.
No.
No, ma'am.
Okay. How are you going to manage your patient?
I am going to investigate the patient with a complete hemogram and urine albumin sugar, urine culture sensitivity, and peripheral smear, stool for occult blood, and stool for ovarian cyst, LFT for serum protein levels, and the renal function test. Ultrasonogram abdomen and pelvis with
Renal function test for what for? Renal function test what for?
Yeah, why renal function test plays a very important role in anemia?
In chronic renal disorders may cause, in chronic renal disease, erythropoietin level will be decreased one. So causes defective erythropoiesis, leads to anemia.
How erythropoietin is very important for this thing. What happened with erythropoietin?
Erythropoietin plays a major role, stimulating factor for erythropoiesis.
Yeah, it plays an important role in erythropoiesis.
Erythropoiesis.
So if it is decreased, then how thyroid contribute in case of anemia? In which case of thyroid, hyper or hypo?
Hypothyroidism.
Yeah, why? It also acts on
It's
the
important for
same level of
erythropoiesis.
erythropoiesis only. So
Production of urinary RBCs, no? The investigation should contain like this. First one, so severity of anemia, hemoglobin, that and all. Then goes with etiology of anemia. And then comes what are the other management purpose you have to do an investigation.
Okay.
For severity, hemoglobin, complete hemogram, all this. For etiology, peripheral smear, bone marrow, and then you said no, RFT, LFT, all this thing. And then management purpose, depends upon the etiology, you have to add higher investigations, like hemoglobinopathy, all this. Other investigation you have to add. Otherwise, nutritional is okay. Accordingly, you have to manage. If you find out something, and then you go along with the etiology, and roll out all the other things. What is the first indicator for iron deficiency by investigation? Earliest. Even before, there are 3 stages of anemia, you know, no?
Iron storage, stage 1, that is iron storage depletion. Stage 2, deficient iron deficient erythropoiesis,
and the frank anemia.
Iron deficient anemia.
For the depletion or store depletion, what are the investigations?
In store depletion, serum ferritin is the ideal marker. In this serum ferritin will be low.
Ferritin. What is the newer investigation apart from serum ferritin? Free erythrocyte protoporphyrin estimation. Okay, so usually there will be 35 microgram per deciliter. It will be increased even before serum ferritin. Okay, and another investigation is transferrin receptor assay, serum transferrin receptor assay, ELISA method. All these are newer. It's not done here, but we are doing serum ferritin. What is the normal serum ferritin?
20 to 200 microgram per liter.
Okay. Below 20, that is the first stage. Okay. And then comes what else? Defective erythropoiesis, all blood indices and peripheral smell will replicate this. Coming to what other investigations we will do? All this is done for chronic anemia. What are the investigations?
Stool for alcohol blood and stool for OVA system.
Which OVA?
We have to look for OVA Ankylostomia duodenum, which is most common in Indian population. It is a thin-walled and not bile-stained egg. It will float on the saturated solution. With the 4 blastomeres will be seen.
That's another pathology people are enough. Okay. Total iron requirement for pregnancy, tell me.
Total iron requirement is
1000
milligram. In which
1200 mg. Split up for 1200 mg. Why this 1000 is required?
Both for fetus and placenta, 300 milligram.
For RBC
expansion, 500 milligram. For basal losses, 200 milligram. For lactation, 200 milligram.
Calculation of iron deficiency. Only calculate iron deficiency. Formulas will tell me.
Iron deficiency.
Gansone is formula, ma'am.
2.4 into HB
Pre-preg-
deficit into pre-pregnancy weight plus replenishment of the stores. We have to calculate, ma'am.
How
500
much of a milligram of iron you will add for the repletion of store?
Storage. How much?
If patient is less than 35 kg means 15 mg per kg, ma'am. If more than or equal to 35
500
kg,
milligram.
It is
500
yeah,
milligram.
universally
500
500 milligram. If you tell,
Universally.
it is more than enough. Okay,
Yes, ma'am.
What other
plus 500
calculation?
milligram.
What other calculation you know?
According to weight basis, ma'am. If patient is having patient is under within less than or equal to 35 kg means if HB more than less than
That
10
and so much
means we give
day-to-day
No,
activity.
don't complicate so much. Madam is
Yeah,
asking
very
another
easy.
formula. It is
Very
simple.
easy
250 into
day-to-day
iron
formula.
deficit plus 500. That's it.
250
250
milligram
into iron
into
deficit
hemoglobin
plus
deficit.
500. Okay,
Plus
it is a
500.
simple formula
Very easy formula.
to remember also. If you don't remember the
You can
complicated
show me
formula,
method.
you can tell this. Okay, if she is having 4 grams of deficit, to the 250 into 4 is 1000 plus 500, 1500. So how will you give a iron in this case? She is 35 weeks and 6 days, I think. So what are you going to do? How are you going to correct anemia in this patient?
She
What
is
is the iron
near
deficit first?
iron deficit in this case is 620 milligram per milligram, ma'am.
See,
So-
what is your targeted iron hemoglobin level?
12 or 14.
What do you want to have now? 12 or 14? Madam is asking
14.
straight away.
12 or 14.
12, ma'am.
12 is more
12,
than
yeah.
enough because she is already 37, 5 weeks you are telling. Okay, what are you going to do? 12? So, 8.5, deficit is 3.5 into
250.
250 plus 500.
15.
How are you going to give? And in which, how many days it is going to increase? In what way it is going to help? That also you are going to see. In this case, how many days you are going to give, and period is very less. It is almost 36, only 4 weeks is left. So,
What iron you will prefer?
which iron you can prefer? In other way.
As she is near term, we will go for blood
transfusion.
Why 8.5 gram blood transfusion, ma? I will tell you.
And also
Definitely, I will tell you.
I asked what type of iron. You are telling
You are
blood
giving
transfusion.
clue again. You are going for blood transfusion. Both are
See,
give clue.
What the examiner asks, you have to answer. Madam is asking what iron.
Yeah.
So you tell, you answer.
When will you give blood, ma? When will you give blood?
in more than 36 weeks, with severe anemia, irrespective of gestation age, we give blood, ma'am. If the patient is more
Okay.
than 36 weeks, HB less than
More than
7.
36, but the 10 also you will give, huh?
Less than 7 means we give transfusion, blood transfusion.
Here it is 8.5, no? Then why are you telling blood?
What is the period? In other words, what is the period of hemoglobin rise if you give a IV iron? How many weeks it is going to take?
3 weeks, ma'am.
Yeah. So,
3 weeks.
you have
What iron
3
you are
weeks.
going
We
to
are
give?
not going to induce the patient in case of anemia because they themselves will go in for
Preterm labor.
spontaneous labor. Okay. If you give blood, they will go in for preterm labor also. What is the reason for preterm labor if you iron blood correction is given in this patient? If you give blood, sometimes they may go in for preterm. Why? That is before that time itself she can deliver. Some reason is there. Because the hypoxia, iron oxygen carrying capacity of the muscles are increased. So muscle may go in for contraction because of good this thing, hypoxia corrected. So may induce the contractions of the uterus, and patient may go in for a spontaneous onset of labor also. Okay, so that you have to always keep in mind. If you give blood, sometimes she may go in for a spontaneous labor. So, okay, what are the complications in an antenatal and a postnatal period if there is a patient is complicated with anemia?
In antenatal period, there may be recurrent infections.
See, if I am a student, if I had been asked this question, I will tell it is the maternal and the fetal.
Okay.
Always classify. If you classify, you won't miss any point. If you don't classify, you will be going on jumbling the points, and at last you will forget to tell something. Okay, so classify. What are the maternal risk complications? What are the fetal complications? Okay, what are the maternal complications? You started telling.
In maternal complication, first trimester, more chances for getting abortion, recurrent infections, and means abruption. In the third trimester, abruption, more chances for getting abruption, and preterm labor, and PH and already existing maternal complication will be exaggregated, and during intrapartum period.
What is the percentage of, don't tell PAH, no more PAH it is called, it is gestational hypertension, it is GHT. Okay, what is the percentage of GHT in anemia? How common it is?
50%. Okay, tell me what are the complications? You told about only what about the her health? So you may go for failure, no? CCM, all these things. Hypoproteinemia, CCM.
Failure.
If patient goes for labor, we have seen, examiners will tell, we have seen so many deaths during labor, those days. Okay. So what iron, again we are coming to what iron. Government supply is what government supply? IV iron.
IV iron sucrose, ma'am.
Iron sucrose, but it has to be given in 100 mg or 200 mg. Other iron preparation, what is it?
Other iron preparations for
Pericarboxy
maltose, ma'am. The advantage
FCM single dose, 1000
FCM
mg.
injection single dose. Okay, because this has to be given in a divided dose, 200, not more than 200, for alternate days, that too. So it will take almost 7 days and the result will be there. So if you give today this FCM injection 1000 milligram in 200 ml of saline, it is going to be in 3 weeks. She may be corrected with 2 to 3 grams of increase in, and this thing hemoglobin will be there. Okay.
Earliest sign of improvement. After iron, earliest sign of improvement.
Earliest sign. Huh?
Within 24 hours, iron containing enzymes are replaced in all this.
First is patient's well-being.
We are not receiving.
Patient will tell, I am feeling good. That will be the first and foremost symptom. Patient will come and tell, now I don't have exertional dyspnea, I am feeling comfortable. That then, if you do the investigation, what will you find?
Increase in reticulocyte counts will be seen after
reticulocytosis. That is called reticulocytosis. More than
count then.
more less than 1.
Starts from 4th day, peaks at 8 to 10 days. Okay. After that 2 weeks, we will tell how many gram of iron will raise. Hemoglobin will rise. How many grams? After 3 weeks.
After 3 weeks, it's 1 gram. 1 gram per deciliter. After 4 weeks,
Daily raises 0.8. Daily raises 0.8 grams per deciliter per day. They are expecting 3 gram raise after 3 weeks.
3 to 4 grams. Don't tell 1 gram.
Plus 3.
Okay.
So 8 plus 3 is 11 grams. Okay. 11.5. So coming to intrapartum management, labor management for anemia.
In intrapartum management,
You never told fetal complication.
Yeah.
FGR, fetal growth restriction, preterm labor,
Low birth
low
weight.
birth weight babies, ma'am.
In
The
postpartum.
baby will have anemia after delivery.
Yes, ma'am. Sorry, ma'am.
Immediately after delivery, the hemoglobin of the baby
Even
newborn
abruption
will
is
be
twofold increase in anemia patients. Abruptio placenta is twofold increase and twofold increase of gestational hypertension in anemia. If it is normal is 10 to 15%, here it will be in anemia complicated, it will be 20 to 25%. Okay.
Yes, ma'am.
What will be the hemoglobin in newborn? You tell me. Anemic mother.
Anemia.
Baby will
about
have
the
anemia
iron?
or not?
Iron stores in the newborn, what will happen?
If the
Before iron store, what will be the hemoglobin in newborn?
hemoglobin will be no change.
Whether baby is anemic or not, you tell me.
No,
No,
ma'am.
ma'am.
Why no, you tell me.
The baby will have
Because it's
sufficient iron stores.
Answer is correct. What is the reason?
In the last trimester, even if the mother is anemic, the total available iron content in mother will be transferred to baby because baby will be through placenta. Even though mother is anemic, the baby won't be anemic because all the stores available
Because
will
what?
be
Because the transferrin in the placenta is regularly going into the baby fetus. Okay. Already trapped the transferrin in the placenta.
Yes, ma'am.
It's going to the fetus. What about a month or two after born?
After a month or two, usually baby will be having anemia
Because of what?
because of exertion of the stores obtained from the mother.
Any stores,
Fetal
iron store will be less.
Yes, ma'am.
So immediately after delivery, what are the complications? Madam asked, you never answered.
Yeah.
Immediately after delivery of baby, there may be a chance of a postpartum hemorrhage.
You come to first stage இருந்து சொல்லுங்க. The labor management of anemia, first stage of labor.
In first stage of labor, we have to allow the patient to take the position whichever is comfortable for her. Then IV lines has to be secured and blood has
What
to
will be
taken
the position? Comfortable position means what will be the position ideal for the patient?
She may be asked to lie down in a left lateral position now.
Somebody is answering propped up position.
Propped up
Always
position.
ideal. Always ideal. Okay. Because these patients are the patients who are going to go in for a failure in any stage and pulmonary edema. So propped up position is always better in any case of anemia complicating cardiovascular complicating diseases. Okay. Okay. Propped up position. Then what will you secure? What will you secure?
IV lines has to be secure and blood has to be taken for a cross
No,
matching.
IV line. IV line le one answer you have to continuously tell. 3-bore cannula. For what?
For 3-bore cannula.
Somebody is answering 2 line also.
Yes, ma'am.
What for white bore cannula?
If as she is anemic, she is more prone for PPH. If we have to manage PPH effectively, we have to start oxytocin and blood. If there is any
So 3-way cannula, white bore cannula is always indicated in a patient with anemia because they are prone for pulmonary edema at any time and PPH also. Okay. Then what are you going to give in the first stage?
First stage, we can advise her to take oral fluids, ma'am, rather than giving IV fluids. And input output has to be monitored. Fetal heart rate and uterine contractions has to be monitored. Then when she reaches a 4 centimeter dilatation, autograph has to be started, in which a descent of a fetal head and a cervical dilatation has to be noted. If there is any rupture of membranes, color of liquor to be noted, and the fetal heart rate monitoring has to be done every 15 minutes once, and uterine contractions to be monitored. Immediately after the delivery of the second stage with water. If there is more chance of maternal exertion, so we have to cut short second stage of labor with the instrumental deliveries.
So it is cut short the second stage,
Second
not
stage of
cut the second stage. Okay, you can cut short the second stage.
second stage.
Instrumental delivery maybe usually second gravida patient usually she'll progress very nicely and then she will deliver very normally. What is the estimated fetal weight in this patient in this pregnancy? Previous it is 2.7 kg.
2.5 kg, ma'am. This time.
Did you tell it in your this thing inspection finding, palpation finding, estimated fetal weight? You never told. You never told. Basically, the estimated fetal weight is how many kg? And Liker is adequate clinically. These 2 points you have to always take.
And cross-talk is there.
Yes.
And the audio is not
Who is managing audio? Field company.
Yes, ma'am. Immediately after the delivery of the baby, we have to go for active management of third stage of labor. That is 10 units of oxytocin IM has to be given, and placental removal by means of controlled contraction.
What about cord clamping, ma? Early or late? Delayed?
Delayed cord.
Reason? For each and everything you have to tell reason.
Yes, ma'am.
What is the
Prevent
reason?
neonatal anemia, ma'am.
Prevent neonatal anemia. So 50 to 80 ml will blood with an hemoglobin will enter, no? Delayed cord clamping. Answer.
Okay.
Common. Tell me the answer. So in the anemic case, even with normal loss cannot be tolerated by the anemic patient. You have to vigilantly watch. What are the drugs you will give?
10 units of oxytocin IM has to be given immediately after the delivery of the baby. The placental delivery by means of a controlled contraction, ma'am. Uterine massage has to be given.
Depends upon the severity of anemia, what else you will give? Suppose the severe anemic patient is delivering, what are the drugs you will give?
20 units of oxytocin infusion has to be started.
Only oxytocin தான் போகுமா? மேல பேஷண்ட் செத்துருவாமா? ஒரு முக்கும் போது மேல அப்படியே நின்னுடும் ஹார்ட்டை பத்தி கொஞ்சம் யோசிங்க.
Injection fusamate.
யோசிக்காதீங்க. கெட்டு புட்டு ஹார்ட்டை பத்தி யோசிங்க.
Injection fusamate 20 mg IV, ma'am.
Yeah, Lasix 20 mg, Deriphyllin, nasal oxygen சொன்னியா? 6 liters per minute. So this must be there. Propped up position, nasal oxygen, and Lasix loaded immediately after delivery of the baby. Even without the placental separation, you have to give Lasix.
Why oxytocin is inducing pulmonary edema? Reason. Why failure occurs usually? Congestive failure is prone in patient with anemia, oxytocin if it is given.
Water retention.
Okay, water retention is the thing. So you never told about the IV fluid. Will you allow the patient on IV fluid, or if she is tolerating oral fluids allowed in an anemia patient? If at all IV fluid should be given, it should be within 75 ml per hour should be given. Okay. So pulmonary edema common, as madam told, immediately after delivery. Congestive cardiac failure is prone. Why? Why?
Influx of volume of blood from the maternal circulation.
Increased preload, ma'am.
Why? You have to tell, you are a PG, you have to tell the pathophysiology.
That's why immediately after delivery, the patient will go for CPR.
Why? Because of the
uterine
contraction of the myometrium, the feto-maternal reserve which is maintained will be pushing the blood into the main circulation, maternal circulation, more than 800 ml per minute. So patient will be having so much of preload, so they are going in for a congestive cardiac failure. This point always you should remember. That's why prophylactic furosemide is given in these patients, either 10 milligram or 20 milligram. Even if you are operating a patient with anemia, you have to tell the anesthetist or immediately after delivery, prophylactic furosemide can be given. Otherwise, patient may go in for pulmonary edema. They will be giving Lasix only after patient is coughing. But being a physician, you are the first physician of the mother. So you have to tell prophylactic is always advisable, because we are practicing in labor room. So popped up position, which is going to decrease the preload. That's why the popped up position, because when the patient is sitting, there is no preload. Okay. So it won't return so easily, it won't return to the heart. Sitting posture may. Okay. Okay. What is the immediate complication in third stage? PPH, you have already told. For that, what you will give to arrest PPH? Why PPH is common in anemic patients? Because of
hypoxia, muscle contractions won't be effective.
So hypoxia, atonicity. So it is a PPH of atonic PPH. So you have to watch always the PPH. Even a small amount of blood loss in these patients is going to cause a hypovolemic shock. Okay. So hypovolemic hemodynamic instability, it is called. So hemodynamic instability or instability is very common in anemic patients. So watch always the PPH. So what will you give? The drug of choices already told, either IV infusion or IM oxytocin with furosemide IV. And then what is the next common this thing? After 2-3 days, you will be watching something and all. What are the things? Complications.
Uterus sepsis.
Complication.
Infection common, subinvolution common.
Subinvolution of the uterus.
If there is a
Important. Patient complain.
Lactation failure.
Patient won't complain or won't complain.
They are worried
She will
about
be
mother
telling,
only.
yeah.
Worried about mother. You tell me about mother. What complication, ma? DVT pulmonary embolism. We are worried about DVT pulmonary embolism death. So postmortem also we have seen so many deaths. Third day, fourth day.
So CVT
Once
is
you won't
common,
forget.
DVT is common. Why DVT is common in anemia?
Why DVT is common in anemia?
Endothelial dehydration and endothelial damage.
In anemia, Virchow's triad. What is the one of the Virchow's triad that is disturbed? In anemia, why DVT? I told you yesterday itself.
Coagulation.
Common.
Pregnancy is hypercoagulable, but what happens in anemia? What happens to the blood flow because of anemia?
Its gauge stages will be venous stages.
Sluggish, no?
Stagnant flow, ma. It is why DVT? DVT nalme adu vandittu indirectly it is telling that flow is not correct. So you tell stagnant flow. It is not flowing properly. That may be the reason for DVT, which is going to give rise to a pulmonary embolism. DVT can be corrected by giving medicine, but pulmonary embolism is a life-threatening condition. Immediately it will kill the patient. So we are more worried about DVT going for CVT and pulmonary embolism. We are more worried. So always this thing anemic patient, if they are bleeding more than 500 ml in a normal labor, you have to be more careful. Immediately you have to do this thing. If immediately you are doing a this thing HB, it is coming out to be normal. What must be the reason?
Hemo
Good, correct.
concentration.
Hemo concentration will be there immediately after delivery. So it will be giving a very wrong values of hemoglobin. So you have to see the clinical symptoms. What you as
Also
signs and symptoms.
dehydration.
You have to do it, and then you have to do after how much she is lost. You have to really replace that thing, and urinary output per hour will give you the exact results whether patient is going in for hypovolemia or not. If there is hypovolemia, patient is not going to produce more urine. She will go in for oliguria. So all these things, signs will be always there for us to detect. So always keep the patient. What is HDU care?
These people must be in HCU delivery only, no ICU or HCU delivery.
What is HDU care? What do you mean by HDU?
High dependency. High dependency unit.
Louder, please.
Well, what is high dependency unit? It is my thesis actually. That's why I'm asking.
Yes, we are not conducting exam. We are teaching.
Yeah, we are teaching. Just commit mistake here so that you won't commit mistake in anemia
Real
in the
exam.
exam. So learn here. So commit mistakes. Open your mouth. Just discuss.
One-to-one care has to be given. Close monitoring of the patient by maintaining proper input and output chart, and vitals, continuous vitals monitoring.
High dependency unit means it is a multidisciplinary unit, and that unit will be having a ambu bag, boils apparatus, all these things, just like a ICU. You have to revive the patient if she is going to collapse in the labor room itself. That is called high dependency unit. You will be having 24 hours multidisciplinary, and then you will have a round the clock anesthetist will come and revive. Intubation will be done in the high dependency unit. Blood transfusion will be given there itself, and patient will be put into ventilator if needed. All these things, it is a high dependency unit. It is a ICU care in a labor room setup is high dependency unit. So you have to do all these things. First, you have to diagnose whether the patient is going to fail. In all the high risk patients, observe these patients at least for 6 hours in this high dependency unit, and then only send the patient to the normal ward. Okay, so this high dependency unit monitoring is very, very important in anemia also, because patient may go in for congestive cardiac failure. Why congestive cardiac failure is very common in anemia? Already you told about the preload. That is during delivery, 800 ml is shifted. Next. Anything else during puerperium?
Abdominal lactation pain, all this they told them. Unbooked gave 4 gram hemoglobin. In labor, what will you do? 4 gram. Unbooked. Term in labor.
We have to put the patient in a
HCU admission or ICU admission. Call for cardiology help also. Will you give blood transfusion factor or exchange transfusion?
Partial exchange transfusion.
What is exchange transfusion?
In this,
You are
blood
doing exchange transfusion in your institute.
Yeah, have you seen exchange transfusion?
Have you done or have you seen? Because we are not doing, that's why I'm asking.
Those days we have, I have seen.
No, madam. In modern obstetrics, there is no amount of exchange transfusion. No.
Yeah, in IOG, no.
Rather than that,
while I was an assistant, I have done it, but not now.
No, rather than giving a exchange transfusion, you can now give one thing.
Yeah,
what is that called?
Those days, no ICU, no cardiologist. We ourselves have to do. So in one hand, we will remove the blood, and another hand, we will put factor simultaneously. You have to remove 500 ml blood first, then start factor in another arm slowly with elastics. So many cases we have done as a PG and assistant. But now the ICU is well equipped and cardiologist, everybody is there. No need for exchange, but with the last week we can give parcel. But you have to establish 1000
It
ml of
should not be
urine.
a whole blood. Whole blood, rather than giving
But
a
you have
whole
to
blood,
last
give a
week,
packed cell. That will do.
last week
Okay.
and establish 1000 ml of urine, then start parcel. It will not cause overloading. So first give 60 milligram, 80 milligram last week and eliminate all the fluid, 1000 ml, and then start parcel. Nothing will happen.
Yes, ma'am.
Coming to other anemia, folic acid, megaloblastic anemia. What is the normal value of folic acid and B12?
B12 has to be more than 90 nanograms per ml. Red cell, folic acid, serum folate has to be, when it is less than 2 nanograms.
Serum folate only, not the RBC folate. Serum folate, you tell me the value.
In megaloblastic anemia, less than 3 nanogram per ml.
Serum folate will be less than
Less
3
than
nanograms per ml. And red cell folate will be less than
How much you are giving?
Yes, ma'am.
Folic acid. Usually we won't give B12, no, only folic acid we are giving first trimester. How will you diagnose B12 deficiency? If you give folic acid in B12 deficiency, what will happen? Without correcting B12,
worsening of
peripheral.
what will happen? Worsening of symptoms? What symptom will exhibit in B12 deficiency worsening?
Numbness of
peripheral neuropathy.
All early symptoms. Sometimes the patient will go for CNS problem also. So we have to rectify folic acid, then only we have to give B12. What is the peripheral looks like in megaloblastic anemia?
First symptoms will be hypersegmental neutrophils, macrocytic erythrocytes, and basophilic stripling, oval
Megaloblastic, bone marrow will be megaloblastic. With iron deficiency, usually goes with B12 and folic deficiency. No? So dimorphic anemia is so common. Apart from the anemia, iron correction, what are the nutrients you will give to enhance the absorption and enhance the hemoglobin value? Only iron and folic acid you will give, or apart from that, what else you will give?
To increase iron absorption, zinc and vitamin C will be given, ma'am.
With vitamin C, zinc also can be given. Zinc and vitamin C preparation can be given.
Like zinc, magnesium, copper, all these things. Apart from that, very important is the protein. All the apoprotein, transferrin, all these proteins are you have to supplement. So you have to give protein rich diet also. Then only the anemia correction will be enhanced easily. Okay. Okay, ma'am.
Okay.
Raji ma'am, you have to tell something. Rajeswari ma'am. Hello, can you able to hear me?
Yes, ma'am.
Yes. Any doubt, ma'am? So management, contraception, what contraception you will give? After delivery, what contraception? What, ma'am? Contraception advice.
This patient is
contraception.
second gravida, means we will advise sterilization, due permanent contraception.
This patient, 8.5 will come down to 6.5. Anesthetist will give anesthesia for 3 years. No. Then what contraception you will advise?
Progesterone only pills are copper.
What about IUCD? CPIUCD.
Puerperal sepsis means
Improve iron in 3 months and come for permanent. The patient doesn't willing for permanent. Both female baby doesn't willing for sterilization. What else? After improving iron, you have to introduce IUCD. Okay. Why the not OCP? Oral contraceptive.
estrogen thrombosis, ma'am.
Thromboembolic
Thromboembolic phenomenon is more common with anemia with OCP because DVT is common with estrogen.
Okay, and that's why you shouldn't be, and also in the insulin pills we are not going to do because it will suppress blood pressure. Okay, so we have to put IUCD varying in rest of the people receptors. So improve iron and then give IUCD.
Patient is coming after IUCD insertion with post IUCD menorrhagia. What will you do?
You have to reassure, remove that. You have to remove.
We have to remove it and we can go for not plant and implant or low progesterone only pills. We have to remove it, okay? Already she is anemic, no? Don't take risk.
So give a DMPA injection for first contraception. So see for either she is complaining of anything, water retention or IBP, anything like that if she is coming for. Otherwise, you can give that injection, wait for 3 months, then ask the patient to come again and see the anemia status after delivery, whether she is increasing in her anemia. This thing she is getting rectified with oral iron. With 3 months, we can know that. And at that time, you can really counsel. This is the thing because she can't take OCP and DMPA can't be completely given for every time. Either barrier contraception, which is going to decrease the incidence of STD also, as well as any other infection. And you can counsel barrier if the husband is not willing to.
Barrier is best, but the husband is not
but
accept
none
it.
of the male will accept.
Yeah, they will not accept it.
Yeah, acceptance for a barrier contraception is 0.5% in India. They won't accept. So for that only, you have to advise the patient, counsel the patient what can be done, and you can really ask them to come, then work up for anemia again, see the hemoglobin status, put the IUCD, then see whether she is really bleeding, and then you can monitor the patient with the immediata. You need not remove. The first episode of every patient will have post-abortal, post-natal, anything. If you insert IUCD, immediately after they will have one bout of definite menorrhagia. So you can control the bleeding with Trapic MF or all the other NSAIDs. Tell them you can. Watchful expectancy is very much needed here. Immediately don't remove it. Ask the patient how much she is bleeding. Bleeding is always subjective, not objective. So objective scoring you have to make. Whether she is really drenching the whole pad and she is using more than 5 pads per day. All those things you have to ask. Immediately she is telling, Amma, don't remove the copper T. You just see, you calculate the blood loss, see whether she is bleeding more than 80 ml, then you can remove it. Otherwise, you can ask her to go with Trapic MF and post this thing period hemoglobin level. If she has really lost blood, we can assess the loss and then we can think, okay, this patient is not a candidate for IUCD. Okay, what is the most common thing after IUCD insertion in anemic patients? And why? Common complication.
Infection.
Infection. What infection?
Vaginal discharge.
Endometritis.
Endometritis, all those things. Huh?
Infection peculiar to IUCD.
Peculiar to anemia.
Actin.
Yeah, tell. I told you, no commit mistake here.
Actinomyces.
Actina.
Actinomyces, they are telling, madam. Actinomyces.
Actinomyces or sometimes it's not even for postnatal or any IUCD incisions.
Any IUCD. But why postnatal means postnatal is prone for infection. Because the house is very much opened, all those things are there. And it is a fresh endometrium which is already bled, having a open up wounds, all those things are there. So immediate insertion, endometritis, and the infection is common with the actinomyces infection. Any IUCD, the most common infection is actinomyces.
Patient complaint will be leukorrhea. After IUCD, patient will complain of leukorrhea. Then pain abdomen, lower abdomen.
That time you are going to remove. That time don't tell the patient, go with the antibiotic, come after 3 days. If you really feel there is endometritis and she has gone in for infection, and if you feel that is IUCD is the reason, then you can remove it. Okay.
We
So-
want anemia. Basic question, sir. Sir, the anemia and failure is interchangeable or not? That's two words, sir. Basic. Is anemia and failure is interchangeable or not?
No. No, ma'am.
Open your mouth, ma.
No, ma'am.
Yes or no?
No, ma'am.
No. Then you tell me what is failure, what is anemia.
Failure is the clinical sign
Louder, please.
Failure is the clinical sign we observe, ma'am. Clinical anemia is failure.
Okay, clinical sign due to water. Anemia is pathological, okay? Failure is a clinical sign due to what you tell me. When will you say failure? Because of what you are seeing failure.
And where will you see the failure?
And where will you see the failure?
In palpable conjunctiva mucosa.
Basic UG question, ma, this and all.
Male beds.
It depends upon the thickness of the skin
Where
and
will you see the
conjunctival
failure, ma?
underlying capillaries with the blood, underlying capillaries, the blood capacity, all these things we can see in the failure may be mild, moderate, severe, no? But anemia is original pathological hemoglobin concentration or deficit. Or this deficit is anemia. So failure can occur not only with anemia, but some other condition also. Then all failure are not due to anemia. Yes or no? Can you able to hear me?
Yes, madam.
Tell me the answer.
Sir, madam is audible. Le. Madam,
Hello?
good morning, madam.
All consultant are seen. No PG is seen. Sampath, how are you? Where is the PG? It's gone with, from screen. They're searching for answer, huh? It's a book. Madam, Jaiti madam, PG screen liye illiye. PG ஓடிட்டாங்களா ஸ்கிரீன்லயே இல்லையே.
இருப்பாங்க. ஓ அந்த
எல்லாரும் faculties தான் இருக்கிறோம்.
not in video. மத்தபடி they must be there. இல்ல ஜாயின் பண்ணிட்டு காண போயிட்டாங்களா?
காண போயிட்டாங்க.
யார் மேடம்?
இல்ல இந்த presenter
பண்ண மாட்டேங்கறாங்களே.
presenter the last link it seems.
They must have lost the link,
ரேவதி
madam.
மேடம் நான் கொஞ்சம் லேட்டா
Yes,
join
ma'am, they got
பண்ணேன்.
disconnected.
Okay.
Anyway, time is 7 o'clock, I think.
Thank you, ma. Thank you, madam.
மேடம் நான் லேட்டா ஜாயின் பண்ணேன்.
Okay, no problem. I
Thank
thought
you,
as
madam.
much. You must be
Link
having
is
some
cut,
work.
I think, madam. Link is cut. They are not
Ah,
there.
ஆமா.
ரேவதி
நம்மளா
madam
question கேட்டு நம்மளா answer பண்ணிக்கணும். We have to
ஆமா
ask
PG
this
சார். PG கிட்ட சொல்லுங்க பயந்துருங்க. ராஜராஜேஸ்வரி மேடம் சொல்லிடுங்க நல்லா பண்ணாங்க. பயந்துர போறாங்க.
Thank you, madam. Thank you.
Thank you, ma'am.
ரேவதி
Thank
மேடம்
you.
நாங்க எப்படி கேள்வி கேட்டோம் சொல்லுங்க.
nice. நல்லா பண்ணாங்க. Very good. கொஞ்சம் பயந்தாங்களே நல்லா பண்ணிட்டாங்க.
Thank you,
ஆமா.
madam. Thank you,
Anyway,
madam.
பசங்க நல்லா
Thank you, madam.
பண்ணாங்க.
Thank you. Thank you.
Thank you.
So
Thank you.
for completion, I will go with the vote of thanks.
Thank you,
Oh,
madam.
yes.
First of all, Padma madam and
Kalyani
Kalyani
madam.
madam, sama discussion. நீங்க ரெண்டு பேரும் ஒரிஜினலா அந்த பிள்ளைங்களுக்கு எக்ஸாமினரா போயிடுங்க.
Thank you, madam. Thank you. Thank you, madam.
Anyway, Rajarajeshwari madam, thank you. First of all, I thank our president, Dr. Revati madam, for the first Bodhana series in her tenure, that was starting with anemia. And I thank that Tanjavur PGs and Rajarajeshwari madam. I have given them that time only for 3 weeks, I think. And I thank the external teachers, Dr. Padmavati madam from Panimalar Medical College and Dr. Kalyani madam from Railway Hospital. And I thank all the students who have
Who
participated
joined?
in this.
More than 76 joined, madam.
Yeah.
Top
Yes, madam. In the
But they have
YouTube,
left.
YouTubeல நிறைய பார்த்திருப்பாங்க மேடம். நாளைக்கு
Okay.
நமக்கு தெரியும் amount.
Okay, ma'am.
I thank our
Thank you, ma'am.
coordinator,
Thank you.
Dr.
Thank you.
Kalpana, for the wonderful. So PGs, every month, last Saturday, we will be having this program.
Yes,
Next
ma'am.
month, January 28th, we are having fibroid complicating fibroid.
Okay, ma'am.
That is from the Bangalore Narayana Health Dependent students are presenting and externals are from Madurai. So
Okay,
all of you, I request everyone to join that. Revati
Send the
madam,
link to me also, madam. I'll
Yeah,
also join.
send the link to me
sure,
also.
sure, I'll send the link. And we thank the Shield, who is always our scientific partner.
Thank you, ma'am.
Sampath, not only students, members, நம்ம societyல individual societies also should share in the group.
Yes,
So that they
madam.
can also join. Many are not
Okay.
It's
aware.
the benefit of all the PGs, madam.
Yeah.
The exam going PGs will be benefited by
Definitely,
this.
definitely,
Yeah.
definitely. Anyway,
Yeah.
Kalyanji and Padma, Rajarajeshwari
Thank
really
you, madam.
enjoyed the way you.
Thank you, ma'am. Thanks a lot.
Gomati and
Thanks a lot.
Ilakya, you have done well.
Thank
இந்த நெகட்டிவ் பாயிண்ட்ஸ் எழுதாதீங்க என்ன ஒரு டயக்னோசிஸ் அரைவ் ஆயிட்டுன்னா நெகட்டிவ் பாயிண்ட்ஸ் எழுதக்கூடாது அந்த டயக்னோசிஸ் தகுந்த மாதிரியே தான் எழுதிட்டு போகணும் ஓகே
பசங்க இல்லன்னு நினைக்கிறேன்
எல்லா
மேடம்.
ஹிஸ்டரி எழுதணும்னு அவசியம் இல்ல
லிங்க் போயிடுச்சு.
கண்டுபிடிச்ச பிறகு அதுக்கு பக்கவையான பாசிட்டிவ் நெகட்டிவ்ஸ் தான் எழுதணுமே விட அன்னெசரியா அந்த இம்யூனிட்டி எக்லாம்ஸ் அந்த கண்டாவில எழுதணும்னு அவசியம் இல்லை ஓகே என்ன டயக்னோசிஸோ
Unmute
அதுக்கு
yourself and thank. Yeah.
Anyway, thank you, madam. Thank you.
Thank you. My sincere thanks, madam. Revati
Yes,
madam.
madam.
Thank you.
Me
thank
also
you.
thank you very much, madam, for including me in this beautiful
myself
discussion.
also,
Definitely,
I'm
madam.
privileged.
myself also thank you
Thank you.
My
Thank you.
sincere thanks to the
Thank you,
two
Dr.
externals,
Kumari,
madam.
madam.
Wonderful. You
It's a
asked the
recap.
questions wonderfully, madam. Madam,
Yes.
Padma,
Thank
madam, and
yeah thank
my
you
sincere thanks to the externals, madam. You have asked wonderful questions, madam.
Thank you, ma'am.
It was
Thanks.
really
you.
an eye opener. It was extremely nice. Thank you,
Thank you.
madam. Thank you, everyone,
Thank you.
madam. Thank you.
So
Thanks a lot, ma'am.
Rajarajeshwari madam will
We'll
be
see you
coming to
on
send-
January 28th. Bye bye.
Yes, madam. Yes.
Yes.
Okay.
Yeah,
okay.
go, madam. Definitely, yes.
Sure, sure.
Thank you. Thank you.
Thank you. Thank you.